Great. And then I'm going to introduce Steve. Dr. Sugden is the Associate Professor and Associate Addiction Fellowship Director at the University of Utah. He completed his medical school at the University of Utah and later completed his residency in psychiatry at the University of California, Davis. He completed his MPH through the University of California, Berkeley, and his MSS through the United States Army War College. He works on an addiction medicine consult service at the University of Utah Medical Center. Additionally, he's an associate training director for addiction psychiatry and addiction medicine fellowship. And he was a part of leadership at ACLM for the mental and behavioral health MIG, and he's been a colleague and friend for many years. So I'm very excited to have him start off this conversation, monthly conversation about lifestyle psychiatry with our group. Steve.
Thank you. I'm just needing to click the right buttons. Give me a there we go. We all talk about how long have we been doing Zoom, and then we get performance anxiety and we push the wrong buttons. So thank you very much.
We can't see it. We can't see it.
No, darn it.
No.
Okay, now?
Yes.
Perfect. So I'm going to be talking to one of the pillars of lifestyle medicine. Medicine is that of reducing risky substances, and so today I'm going to be talking about how lifestyle psychiatry works very effectively as an augmenting strategy for the reduction of risky substance use. I have no disclosures to have. I think just as acknowledgement, today is World Mental Health Day. It's sponsored exclusively by, the WHO has really been pushing this as something where we take pause. And so mental health is a universal human right, and really want to advocate that we take the moment and think about our own mental health, those of our close friends, and continue this hard work that we do. Also, as I go with our outline, yesterday was Indigenous Person Day, and want to acknowledge, I'm here at the University of Utah and would like to acknowledge those here who were in the Native communities here in Utah. Apart from this, we will then talk about an introduction. We'll be talking about the addiction pathways. We'll talk about why lifestyle psychiatry, and then we'll talk about the lifestyle psychiatry interventions. And if there's any questions, we'll go to that point as well. So many who are on this call have been working with substance use and know that the numbers of prescription opioid death, fentanyl, the numbers continue to keep growing. Most of our numbers that we have are pre-COVID, and they were not good before COVID, and they're getting progressively worse even after COVID. Pre-COVID, we were looking at about 21 million people that had been diagnosed with a substance use disorder. 10% are receiving some type of treatment. 92,000 people died from an overdose use in 2020. These numbers, again, are quite familiar, and they go as far as what we've had through 2020. When we look at data that's come from a recent Kaiser family poll tracking from July of 23, their data shows that, again, that the increased use of alcohol and opioid use has been increasing. And even though we had an opioid crisis before the pandemic, they're yet further calling it an epidemic. And 2/3 of Americans here within the United States can identify somebody who's personally associated with who has a substance use disorder. And so more specifically, when they look at this, more than 50% of people feel that it's had a major impact with their personal families. More than 50% of people say that it's impacted their own mental health. And more than 50% said these substance uses have also affected their family's financial situation. Again, when we look at how much worry this is causing, many people are very worried or somewhat worried with regards to their mental health, with the increasing growth of fentanyl, with increasing growth of alcohol use disorder. Um, and these numbers are fairly consistent, whether they are across ethnicity or they are across um, those with financial means or not. If we step back and even look larger within the global picture, the numbers are equally as staggering, where we have high numbers of it, especially within South America, Central America, um, even in Europe and Australia. Cannabis seems to be the substance of use of choice throughout that is highest used. And we've seen numbers of here on the left, which is fairly common within the United States, and this refers to the world. And when they take in substance use with regards to amphetamines, cocaine, opioids, the indirect cost, the worldwide trend is very on a similar trajectory that we see within our opioid use disorder, where again in 2019, more than 500,000 people had a death due to substance use. And when we look here on the right with the DALI, the effect of DALI and substance use, these numbers are also continue to increase to show that there's significant disability throughout the world related to the substance use. So when we think about substance use, many of us are focused or think immediately on dopamine and receptors within our midbrain and our limbic system. And primarily, our dopamine is manufactured in our brain within the ventral tegmental area. And historically, when our brain is working right, it has a pulsating release of dopamine to our nucleus accumbens. And our nucleus accumbens is kind of like our shipping center, where then it ships dopamine out throughout the rest of our brain. And in a good day, when we wake up in the morning, we want a little dopamine to get us motivated, because it helps us when it gets to our prefrontal cortex, that it gives us our concentration, organization, focus, reward. And we talk about why is, if this reward pathway is so damaging, why was it evolutionary important that we developed it? And really, when we look at from an evolutionary perspective, to promote our species, we needed to have rewards for food, water, sex, child rearing. And these were the initial things that produced this reward. And it kept the human species viable. However, as stimuli have become in more excess, usually in a lot of these same areas, we then have this pathway that it has become so altering for us. And so, when we look again, if this was a study by Dechar et al., where they placed electrodes in mice, this came back in the 1980s, and they could monitor that if they gave rats food to these rats, that their levels of dopamine with their baseline dopamines increased, and so it kind of rewarded behavior. If it had sex, it increased it by twofold. And then when they started looking at the impact of substance use, I'm going to start here on the bottom left with nicotine. The nicotine is almost a 2.5-fold increase. Morphine is a 2.5 increase. Cocaine is almost a fourfold increase. And then when we get into the amphetamines, this is between a 10 to 11-fold increase. And so if we come back to our model, this was, again, the nucleus accumbens. When you have that much trigger of dopamine, now all of a sudden, the nucleus accumbens starts releasing a cortisol releasing factor to the amygdala to create this idea of salience. And in response, this process reinforces neuroinflammation within the nucleus accumbens, so that then there's change structures within the nucleus accumbens, and it now, instead of wanting a pulsating fashion, it's wanting to have this this continuous amount of dopamine release. And whenever there is less dopamine, an individual then starts having withdrawal symptoms. And once we have more dopamine within the nucleus accumbens, then it's able to help us focus, concentrate, and organize. And usually more times than not, this initial focus, concentration, organize is helping us. How do we obtain more of those stimuli to keep this circle going forward? Unfortunately, this then requires more dopamine, because the nucleus accumbens tries to downregulate the amount of dopamine receptors, because dopamine can be neurotoxic. And so as it's down regulating more dopamine receptors, the whole system wants more dopamine. So then it requires the intake of higher dopamine, or we have more extreme behaviors to then have more release of dopamine. But at higher levels of dopamine, this prefrontal cortex concentration, organization, and focus that we initially were getting essentially comes offline. And the dopamine then starts reinforcing only short-term rewards, and it dampens the long-term reward process. And so then for those of us who've been working with individuals who have substance use disorders, and we try to ask our patients, can you think about the long-term effect? It's so hard for people because they just get this short-term focus only. And a lot of this is the reward, the pathway of the dopamine. So why lifestyle psychiatry? Well, how do we rewire our brains? From those of us who grew up in the 80s, we know about this campaign of just say no. We say no to crack, we say no to drugs, um, or we say let's have more willpower, because if we can just have more willpower, we can have the fortitude to be able to say no. But in the end, these strategies just reinforce shaming techniques, and by reinforcing the shaming, it propagates our ability to not say no, and propagates us to want to have higher uses of our substances. So now the next idea is maybe we should look for the magic solution. And many people want a one-time remedy, whether it is a one-time experimentation of this agent, or a one-time treatment of that agent, or we feel we need to get on the right combination of psychiatric medications, or we need to be able to have that one-time rock bottom experience or consequence, that once this happens, then that's going to make us, so then we will automatically want to change. There is a role for pharmaceuticals within substance use. We know that people die if they get into withdrawals. We know that there are good FDA-approved medications for this, for substance use. And I often look at it that this is a series of, we need the scaffolding around us to be able to protect our brains, so we can then be able to make the lifestyle changes. Too many times people focus on the medications without wanting to do any of the lifestyle corrective changes. And really, it's this combination of where lifestyle psychiatry works is we use what is then is appropriate medication when needed, and we augment it with these lifestyle changes, and now we can have a growth mindset, and we can promote change. So lifestyle medicine is based upon 6 pillars, which were developed back in 2004, which a lot of this was developed out of the cardiac rehabilitation research that was some of the founding fathers of this was Dean Ornish and various luminaries who worked within the cardiac health science, and they came up with 6 pillars to help promote improved lifestyle from chronic illness. And these include regular physical activity, having primarily a whole food plant-based diet, having restorative sleep, improving stress management, positive social connections, the avoidance of risky substances, and that this is an adjunct modality that, when used together, can help prevent and often reduce the effects of chronic illnesses. And I would propose, especially with substance use. And so here on the left is a model that Dr. Molo developed, an idea that when we're talking what is lifestyle psychiatry, we're talking more than just wellness or positive psychology. We're talking more than just mental health. We're really including the whole aspect of brain health. And many times when we talk about brain health, we often talk about that this is the neurology folks, where we're talking about the Alzheimer's literature, and the concept that Dr. Malo is really pushed forward, that this is really all of our work here should be focusing on the health of the brain. And when we look at what is for the health of the brain, and we look at the 6 pillars of lifestyle, really at the heart of all of that is lifestyle psychiatry, because how much behavioral change occurs without the right type of lifestyle psychiatry, or the motivational interviewing skills that often comes in really, the argument of through lifestyle psychiatry is that lifestyle psychiatry is really at the pillar of all of the lifestyle medicine chain, the lifestyle medicine pillars. So when we have lifestyle change, we're actually able to decrease the neuroinflammation, which was some of the effects that occurs from the substance use. It promotes serotonin, and as we see, serotonin is one of the agents that promotes synaptic plasticity and neurogenesis. And if you look at the serotonin tracks within the brain, they overlap in all of the places where we have the dopamine targets. And this is one of those agents that actually helps promote the neurogenesis within these regions. It also enhances mitochondrial biogenesis. It promotes the sense of contentment. So let's look at the remaining part of the talks. We're going to talk about the 6 pillars of lifestyle medicine, and talk about them specifically with regards to substance use and the dopamine model that we've been talking about. So for years, most people, when we've talked about substance use, one of the first areas that we talk about is that of having people increase their physical activity. And there have been several meta-analyses that have advocated that this has been a very effective form of not only helping with substance use, but it's also been able to show that it reduces anxiety and reduces and depression. However, further meta-analyses have shown that, in fact, exercise does not reduce the amount of consumption for many individuals, like it was originally thought in some of those studies, when they tease out the actual anxiety part and the depressive part. And perhaps where they find that it is most effective is that the exercise use, it perhaps is a tickler within the dopamine network, because when we have high rates of exercise, it also can produce, the endogenous opioid receptors. It has also been shown to help increase BDF concentrations within the hippocampus, and it helps restore better memory. More importantly, physical activity has been linked to decreasing in neuroinflammatory markers, specifically the IL-6 markers within astrocytes and microglia, which helps restore a lot of the limbic brain circuitry. This is also decreased if we decrease our adipose tissue, it also affects the IL-6 markers. Very interestingly, if we have regular physical activity, it also massages, for lack of better words, the raphe nuclei, where it is then more effective release of serotonin. Um, it also helps improve our sleep quality, which is one of the defining markers of individuals who are prone to relapse, is when their sleep deteriorates. The second pillar, which I want to talk about, is that of eating healthier. And so we know individuals who have substance use disorders have higher rates of malnutrition. They have decreased protein consumption. They have decreased fiber consumption. They have decreased vitamin consumption, especially with our B1s, 12s, and B1, 2, and 12. They have decreased mineral consumption with iron and magnesium. They have a higher likelihood of food insecurity, and they have a higher utilization of ultra-processed foods, which again, when we think about all of these, have many ongoing health consequences of themselves. To get a healthier gut microbiota, we want to be able to feed it again with the things that are really what individuals with high substance use disorder are not having, and that is plants and fibers with short chain amino acids. It's interesting because it's through a healthy gut, we're able to get tryptophan and have better tryptophan metabolism, which is then the source of serotonin through the kynurenine system that we're able to then have that transferred to our brain. Where do we get our sources of tryptophan? Again, the best sources are through plant-based products. And to see this done again, another form of this is healthy gut bacteria leads to increased short chain amino acids, which when it's broken down, gives us increased serotonin production, which leads to the improved neuroprotection. We'll talk now about restorative sleep. And so what happens when we have poor sleep? We know that we have increased phosphodiesterase 4A. This changes the gene expression and neural excitability and ultimately results in decreased hippocampal volume. We also know that we have poor sleep. It promotes us to have an overconsumption of ultra-processed foods. We have increased impulsivity. Conversely, when we know that individuals with substance use disorder, when it affects their sleep, we know that it has impaired REM sleep. It affects the duration and quality of sleep. It has increased inflammation of the airway, and we've increased daytime irritability and headaches with people who have substance use disorders and poor sleep. So it's kind of like this vicious cycle. The rates are fairly staggering, that about a third of adolescents with substance use disorder have poor sleep, and they say the numbers vary between 36 to 91% of adults with substance use disorder have poor sleep. And so there's this bidirectional relationship that individuals with poor sleep have a higher likelihood of substance use, and individuals with substance use almost guaranteed have poor sleep. Individuals who are working on sobriety, if they have episodes of poor sleep, are highly correlated with return to sleep. We know that two factors that are very effective in helping restore sleep is one is cognitive behavioral therapy I, which is really related to the insomnia and helping people learn their triggers of sleep. And the other one that has been shown to be very effective of improving sleep is that of meditation. And so now we'll talk about stress management. And this was a review article that was by Garland and Howard, and we're big advocates of a mindful-based treatment for addiction. And the reason why they felt that it has been such an effective solution is instead of working within the limbic system and the dopamine system, the mindfulness treatment starts from the top, more of within our cerebral cortex, and works downward and influences from kind of a top down approach. And so what is the mindfulness-based cognitive therapy approach? We see here on the left, it involves 6 steps, which includes meditation, mindfulness, the mindfulness practice, a body scan exercise, a 3-minute breathing space, high uses of yoga, as well as mindfulness stretching. And what it's been able to show is we have decreased cue reactivity. So if I see a trigger that may promote me to have urges to use, and one of these cues that we'll talk about subsequently is loneliness, it helps manage those cues more effectively. It is able to help us shift our values from a drug reward pathway to a natural reward salience. So when we talked about with dopamine, that it shifts us from being able to have short-term values only, this mindful-based cognitive therapy approach reverses that to where we're able to have more long-term thinking. It also improves our executive control. And again, in an ideal world, our executive control is through our prefrontal cortex. When we have this altercation of dopamine, those high rates of dopamine take our executive control over. So let's talk now about positive social connections, which is the 5th pillar. For those who haven't, our Surgeon General put out in March of this year a landmark document called Our Epidemic of Loneliness and Isolation. I'm going to be taking a few facts and figures from that document, and please, his document is phenomenal, and for those who haven't read it, I highly encourage you to read it. As a result of COVID, before COVID, these numbers are staggering. About 1 in 2 people reported loneliness. And so if we have 12 individuals here on our call today, that would mean 6 of the 12 of us have experienced some degree of loneliness. These trends are higher among teenagers and elderly, and this source of loneliness is really one of those huge cues for risk return to use or substance use. And due to this loneliness, many people turn to social media or internet, and this becomes yet another addictive pattern that people use, which then is a precursor to oftentimes to their return to substance use. Again, our Surgeon General talks about loneliness needing structure, function, and quality. And when we talk about having lasting memories or lasting experiences, it needs to be structured, it needs to have function, it needs to have quality. And the quality part is really ideally with more people, that it isn't an activity by oneself, but it's within a group of people. And so again, he shows the trends of what this has looked like over the past 20 years within the United States, of how all of these indices have shown decrease or worsening within the United States. So what does this look like within our brain? So on the top is what we see is our normal dopamine pattern. We've been seeing this and talking about this quite often. If one has fear that is many times due to the loneliness, and it's an initial response, we know that our amygdala starts our HPA axis, And on a good day, the cortisol kicks in, and this starts our fight or flight response. And our fight or flight response decreases our initial dopamine, and this then has this pulsating response to our prefrontal cortex, so we can have an organized response. However, when we have this chronic loneliness, these chronic stressors of fear, of abandonment, what we see is when we have, instead of having the normal response or the normal pulsating response, we have a sustained cortisol response. And so instead of turning off the HP axis, it reinforces and has this positive loop. This results in having continuous cortisol to the nucleus accumbens, and instead of downregulating dopamine, it upregulates the dopamine. It also has a continuous response to cortisol. And so now we have two things that are really taking our prefrontal cortex offline. And so this chronic stress of loneliness really decreases our prefrontal cortex. It has this auto repeat loop within our amygdala, and it really affects people's ability to think and to have positive social isolation, positive connections, because of the brain circuitry. So, again, back from the Surgeon General, we often talk about the impact of what substance use might be, and many of us saw how actually the degree of sitting was as impactful as smoking 15 cigarettes a day. Well, if we look here, the lack of social isolation is even more significant than smoking 15 cigarettes a day, about drinking 6 alcohol drinks a day, our physical inactivity, obesity, and air pollution. And so it's worsening our mental health. It increases this community mistrust. And in a sense, where do we turn to when we have social mistrust? Oftentimes we turn to our substance use. We rely upon more on social media. We decrease our physical activity. We have unpredictable sleeping patterns. We have a poor diet, and we can see where this goes. The final thing that I'm going to talk about is the avoidance of risky substances. And yes, we've been talking about this as a whole talk on opioids, perhaps. But the risky substance that I'd like to end on is that of ultra-processed foods. And so this was a study that looked at our dietary patterns during the early 2000s, the 2000s and 2010s, and it looked at the percentage, where we were eating. And I will kind of gear you to where I would like. Between 50 to 60% of our diets with males or females are with ultra-processed foods. When we break this up into our ethnicities, non-Hispanic white, non-Hispanic black, or Hispanics, again, we see this trend that about 50 to 60% of our diets comprises of ultra-processed food. What does that look like? Our sugars we're getting from sweetened beverages and dietary snacks. Our saturated fats we're getting from sandwiches and snacks. Sodium we're getting them from sandwiches and snacks. And so this is really where we're getting a lot of our ultra-processed foods. We've talked about this pathway quite a bit. One thing that we haven't talked about is where our endogenous opioid peptides trigger this. And this is significant because this is where opioids enter into the system. What is equally staggering is this is the same spot where ultra-processed foods trigger in our brain. And so there's been a lot of discussion of those of us who've been working within substance use populations, that what is the gateway drug? We talk about, is it cannabis? Is it tobacco? Is it this? And really, what a lot of experts are predicting, that it could very well be the ultra-processed foods as our gateway drug to this risky behavior of substances. And if we really are trying to make a difference, perhaps this is one of the discussions that we need to start having with our population. And so again, ultra processed foods have no fiber. Um, it is very damaging to our gut microbiota. And so when we look at this in a perfect world, our guts are healthy, we get good neuroprotection. If we take out dietary fiber of this, we decrease our serotonin, and now we take out our neuroprotection as well. And we are really setting up our brains for unhealthiness. So on why we need to have this lecture and why we really are excited that all of you have joined this is what's happened on lifestyle due to COVID. When we look at what our eating habits have been, this was a study that surveyed our friends in the UK, and essentially 4 out of 5 people had changes in one of these areas. So they had worse healthy eating, they had increased binging of food, they had worse exercising, they had worse sleep, and they had increased alcohol consumption. With regards to physical activity, women were less physically active than men, likely because they had more of the child education processes. They reported more barriers, and they reported to have significantly more anxiety. A lot of times is because they weren't able to exercise, which was one of their coping skills to deal with their anxieties. With regards to sleep, more than half the population reported that they had poor sleep as a result of COVID-19 and the lockdown. And when the COVID-19 lockdowns were improved, people did not return to having healthier sleep patterns because they adopted poor sleep during this pattern. And finally, our children, they started this where they had increased consumption of ultra processed food, whether it was from junk food, snacking, they had decreased consumption of fresh foods, oftentimes because there was increased barriers of getting them. They reported having increased boredom and anxiety, and the cycle continued. With this, we thank you all here and who've come to join our MIG, knowing that, excuse me, our new caucus, and this awareness of advocating for change. And I would be happy to have any questions that come up and know how, as a caucus, we can address your concerns and your interests and areas for promote growth within this wonderful new arena that we have. So thank you, Dr. Merlot, for this opportunity.